Today's topic has dominated news headlines for most of this year, but somehow all that coverage has left most of us with more questions than answers. So, here to break down the facts about COVID-19 is visiting policy analyst Dr. Kevin Pham. Thank you for joining us today.
Thanks so much for having me.
All right, so while we wait for our followers to join in with some questions, could you give us a quick overview of the characteristics of this novel coronavirus?
This novel coronavirus is novel, and that means that it's been unknown to the human race for since before 2019, which is when it made the leap from an animal vector to a human. And it's new, although it's new to us. It's somewhat related to the earlier SARS virus earlier in the last decade. And it's also somewhat related to MERS. Those are both coronaviruses as well. What SARS-CoV-2 seems to be like some kind of evolution or some mutation of the original SARS-1 virus. And I should mention that COVID-19 is the name of the disease. The disease is caused by a virus called SARS-CoV-2. It's a respiratory virus. That's in the name SARS, severe acute respiratory syndrome. It causes a severe acute respiratory syndrome in some people. And one of the main differentiating features between this and the previous SARS virus is that CoV-2 is much more infectious. With the original SARS virus, the infectiousness was about between 1 and 2, which means that people who got the original SARS virus would spread it to about 1 to 2 other people on average. What we're seeing, the early estimates for SARS-CoV-2 is that it's spreading between 2 and 4 other people. That's some of the earlier estimates. What we're starting to think now is the case is that it's much more infectious than that. It can go up to 4 to 6, possibly even higher than that. And among people who do get infected, a certain proportion get severely ill. And it's causing this, we've heard about it a lot in the media. It's called the cytokine storm. What that basically is a very severe overreaction of the inflammatory system. And that's not really the direct effect of the virus itself. What the virus is doing is setting off sort of a time bomb that causes the information system to explode. And that seems to be what's causing most of the mortality in the case of this virus. And besides that, it's been a particularly deadly virus. People originally had compared it to the flu. It's certainly not the flu, and it's not like the flu, because in a very bad flu year, such as in 2018, we lost about 60,000 people, a little bit more than 60,000 people. But deaths already attributed to COVID-19 right now is over 160,000 deaths. And so there's some concern about overcounting, but overcounting is not going to account for that 100,000 increase in deaths overall. So it's a very different beast, and it is a novel virus to us, and that's why it's having this sort of widespread effect that's moving so fast and is so unpredictable.
Right, and since it is so infectious, let's talk about these masks. We were told they were ineffective and unnecessary at the beginning of this, and now a lot of places are mandating them. What can you tell us about masks and mask policy?
That was a major foul for the public health establishment. Masks were discouraged at the very beginning, and I think incorrectly so. I think they really should have just leveled with the American people. The stated purpose of discouraging masks at the beginning, preserve mask supplies for healthcare workers and frontline workers who need the masks, and that was. I think they really should have just leveled with us in the beginning and said that, hey, we need to preserve these mask supplies for these people. When they become available, we're trying to ramp up production. When they become available, then we would encourage people to wear masks. I think that would have gone very far in establishing some public trust with the public health. But talking about masks and what they do, the primary purpose of asking everyone to wear a mask is to prevent a person from spreading it to other people. So I should emphasize that it's not to protect the mask wearer, it's to protect other people. And the reason why it works, why it should work, is that people who are infected with a virus but not yet symptomatic, people who will develop but not yet develop symptoms, they stand the most possibility of spreading the virus to other people, because they don't know they're infected. They're walking around, they're interacting with other people, and in doing so, they're infecting other people. If the person who is infected but not yet symptomatic, if they're wearing a mask, then that will greatly decrease the chance that they're going to spread the virus to somebody else. And this is it's sort of common sense. It's a logical conclusion. Whether it's respiratory droplets or by aerosols, the virus is transmitted on our breath. So if you put a physical barrier in front of your mouth to decrease the spread, the arc speed of your breath, then you're going to decrease the spread, the speed, and the arc of the possible transmission. And so that's why we ask for everyone when you're in close proximity to other people. If you're driving in a car, if you're walking by yourself, or if you're walking with your family in your household, then a mask isn't going to do anything because you're already exposed to the people in your household. Or if you're in a car, you're not exposed to anybody else. It's not going to do anything for you. But if you're in a grocery store and you can't maintain that 6 feet of distance with other people, then wearing a mask could potentially have a huge benefit for all of society. And it costs the individual very little to wear one.
And you mentioned this, but could you elaborate? We have a question. Is COVID-19 worse than the flu?
It certainly is. As I had mentioned, the death toll attributed to the death toll attributed to COVID-19 is already over 100,000, and the death toll from a very bad flu year is about 60, a little bit over 60,000. Your typical influenza season will kill between 20 to 30, up to 40 for a moderate flu season. So we're already seeing that this thing has a much higher mortality rate than influenza, and the mortality is only increasing. The season isn't over. There may have been some seasonal aspect to it, but we lost any of that effect in July. So it seems like this thing doesn't go away with warmer weather.
Now let's talk about testing. We have a question. On average, how many COVID-19 tests are performed in the U.S. daily, and how many of those tests are negative?
The positive percent has been fluctuating. I think last week it was about 10%. This week it's starting, last week and the week before it was hovering around 10%, and since then it's been decreasing, which means that about 90% and increasing is negative. The number of tests performed in the United States I think the past few days we've been doing around 800,000 tests a day, although that has been decreasing because of the effect of the hurricane coming on the eastern coast. So some testing centers have closed down and we've decreased a little bit, but before the hurricane came, we were basically breaking records every couple of days as far as the number of tests go. Back in May, we had done, I think, 500,000 tests a day, and then we've increased that into over 800,000 tests a day. So the testing industry is greatly expanding, and it's greatly ramping up its production capacity and its capacity to test too. So, and testing is going to be really important to detect this expected second wave that's coming in the fall. We don't know if it's going to happen, but if it does happen, we need to be able to test a lot of people so that we can catch it earlier on and then hopefully contain it before it spreads too far.
And sort of on that note about the Trump administration's response to this and how the United States compares to other countries and how we've reacted.
Sure. One of the unique features of the United States is that we're a republic. We're a federal republic. So every state is going to respond differently. And the president has been very good about maintaining that federal establishment that we have. And so the different governors are able to respond as they see fit. And where they haven't been able to manage on their own, the federal government has been sending resources. The COVID-19 task force up at the White House has been coordinating with governors and possibly mayors as well to direct supplies. There's been some problems with that. Whenever you have federal coordination of supply lines, it's not going to be very efficient. So there has been some issues with getting the right places, but the White House has been keeping an eye on this, and they've been trying to help wherever they can, and that's a good thing. To let the governors decide on their own what to do. Any meddling from the federal level downward to the states as far as how to respond to this thing, I think, is going to be counterproductive, because the further you are from the ground level reality, then the more difficult it is to have to be able to respond to the actual conditions on the ground. So ideally, cities should be handling most of the response, and then higher up should be the states. So overall, I think the administration has been doing pretty well. There's some, like as I mentioned earlier, there's some issues with messaging. Messaging should be more precise, and they really need to be focused on what people need to be doing and what states need to be doing, and the metrics to get to a reopening state, because ultimately the government's responsibility is going to be to get us back to normal, because they're the ones who closed everything down. So there should be, the guidelines have been out, and they've been doing pretty good as far as that goes.
All right, and another question here about testing. Should I get a test if I have no symptoms? And maybe touch a little bit on asymptomatic spread.
Sure. If you currently do not have any symptoms, but you think you may have been exposed, then it might be worthwhile to get a test. Or if you've been told you've been exposed. I know when managed to go to work for a day before he got an email saying that one of his coworkers had tested positive, so it'd be prudent for him to go get tested, and that would make sense. However, if you're not symptomatic and you've been staying inside for most of the time and you haven't really been exposed much for a prolonged period to anybody else, then it's not necessarily going to be helpful, and it's just going to add more strain to the supply issues that we have right now. And the thing with testing, if you get a diagnostic testing, that is the PCR test that we've heard about, if you do that, then that might tell you if you're infected that day, but it doesn't tell you if you get infected the next day or the day after that. So the utility of that is relatively low. If you get an antibody test, however, and those are available, I think you can just order them online, and they get shipped to your door, and you just you take the sample and send it back in. Antibody tests are going to be more important, because if you think you've been exposed, if you're fairly sure you've been exposed and you get an antibody test and it comes back positive, then that suggests that you've had the virus and then you've defeated it. You might have immunity, by the way, is not invincibility, and we should be clear about that. If you have antibodies, that doesn't mean that you can go around licking people's faces. It's not going to be okay. I mean,
That's
just as far as COVID-19 goes,
okay.
I mean, there's other ethical issues involved there too. But yeah, like the antibody test might be useful. But the diagnostic test, if you have no reason to think that you've ever even been exposed, and it's not going to be quite as useful. And what was the second part of the question?
I think you answered the question mostly,
Perfect.
but if you are asymptomatic, can you spread the virus?
Oh, right. So yes, you can spread it if you are currently asymptomatic. When I say currently asymptomatic, I usually mean pre-symptomatic. That means you haven't developed the symptoms yet, but you will develop it soon. That's sort of when the virus has replicated and transmit to other people, but the body hasn't quite responded to the virus enough to make you feel sick just yet. So it's certainly possible to transmit the virus when you're asymptomatic. Just less. It's so there's two considerations. One is the viral load that you're transmitting out. If you're asymptomatic, then your viral load is relatively low, but you're out in the world more often and you're more frequently interacting with other people. When you are symptomatic, then your viral load is probably going to be really high and you're highly infectious. But if you're sick, then you know you're sick and you're probably spending more time indoors, limiting your interactions with other people. So just from the number of viruses, you're less likely to transmit it when you're asymptomatic. But just from the reality of human nature, just being out in the world, then you're more likely to come in contact with more people and more likely to therefore spread it if you're pre.
And could you talk a little bit about how this virus affects people so differently? Because some people will be very ill, and some people, they don't even know they have it, and maybe they lose their sense of smell for a day or two, but that's it. Why does it affect people so differently?
A lot of proposed mechanisms for why that's happening, and no one knows for sure. We should remember that no one's had this virus for more than a year. Nobody in the world has had this more than a year. So there's a lot of things we still don't know about it. But what we're seeing is that the severe illness is an overactivation of the inflammatory system, the cytokine storm that we've heard about. So some people are just more predisposed towards that. If your inflammatory state is at a baseline level that's higher than normal, then you're more likely to develop severe disease. For instance, people who are obese, people who are overweight, like fat cells are naturally pro-inflammatory. So if you have a lot of fat cells, then you're more likely to develop more inflammation. That's sort of why diabetes is such an important comorbidity. But if you're already predisposed towards inflammation, then you're more likely to develop a severe manifestation of the disease. And then, as we've seen, the elderly population, particularly anyone over 65, over 80, even more so, they are more predisposed to develop the severe illnesses, and we're not 100% sure why. There's a proposed mechanism that they have been exposed to fewer of the modern vaccines, and so they have less cross immunity. That there's some reasoning for that. I'm not sure I buy that, but there's there may be a difference in the immune profiles of different generations. Why the younger generations, they may have been exposed to something that gave them some greater level of immunity, and that's sort of what we're. And this is a little bit different from H1N1 that happened about 10 years ago. H1N1 seemed to attack younger people more harshly than older people, and that of course differs from most other diseases, which attacks the very old and the very young. And so these things are kind of variable. They're not constant from one virus to the next.
Okay, and then talking about children and spread, is there a way we can safely reopen schools?
In fact, and they seem to be the lowest risk also of transmitting the virus to other people. So if we're thinking about all the different activities that we can reopen from in society, then opening up schools is probably going to be the least risky activity to reopen. Like if you're comparing schools to bars, bars are attended by adults. They're in close contact with one another. They're standing shoulder to shoulder at the bar, shouting to the bartender, and they're not wearing masks. So that's a very risky situation if you're trying to contain. Bars are very risky if you're trying to contain the spread of disease, and I'm still talking about COVID-19, of course. You compare that to a school, a classroom, where you have students. You can push the tables, the seats further away from each other. They're all facing in one direction. They're ideally talking to each other very much, and the teacher's standing about 6 feet in front of the first row. So. And adults are not likely to get it from their children. So there's a lot of low risk situations in a classroom, but of course the risk is not zero. So we can try to mitigate the risk even further, and that'll just make it even safer. So, I don't think it's unreasonable to ask students, especially older students, to wear a mask. It's not unreasonable to ask a teacher to wear a mask when they're interacting one-on-one with students. Keeping students cohorts, so like keeping classes together or at least grades together rather than letting them intermingle, that's going to help contain any potential spread. So there are these mitigation measures that can make an already safe activity even safer. So I think schools should be, to the best of their ability, reopened.
And you mentioned once you have it, you're not invincible. So if we have the antibodies, can we still become carriers?
Probably not carriers, but it's still possible to get sick. So one antibody is a molecule that goes and ideally neutralizes the virus, right? But if you have the antibodies and you're exposed to high enough viral load, and this is theoretical at the moment. Theoretically, a virus can overcome the antibodies. Now, what's more realistic is that you might be in contact with someone who has the virus and then get sick again if you haven't quite developed enough of the proper antibodies. So there's multiple. This is going to get into, but there's multiple types of antibodies, and some antibodies are more specific and more effective at neutralizing the virus than others. It takes about 2 weeks to develop those antibodies. So if you get exposed again within those 2 weeks, then it stands to reason that you might get infected again with the virus and become ill again.
Hydroxychloroquine, zinc, and Zithromax should be started the first 5 days of feeling ill. Are doctors prescribing this?
Some doctors are. Most of the doctors that I've talked to don't buy the effectiveness of hydroxychloroquine with or without zinc, with or without azithromycin. I haven't seen there's been a number of randomized controlled trials testing hydroxychloroquine, and most of them, in fact, I think all of the randomized controlled trials, all the ones at least, have come back not supportive of any clinical benefit from hydroxychloroquine. But I haven't seen any randomized controlled trials that include zinc in the triple therapy. So there's still an open question as to whether that's effective, and certainly if it's going to work, if hydroxychloroquine with any combination, if it's going to work, it's going to have to work at an earlier stage. And I talked to a prominent physician earlier this week who said that, yeah, it has to be within the first 5 days, and it has to be It's going to work best for high risk people in the outpatient setting. So people who are, elderly or obese or have a lung or heart, if they start the drug earlier on, and if they start the drug before they develop the severe symptoms, if you get a severe symptom, if you're already on, it's not going to help. But if you test positive, you start the drug right away, then it might help. Again, there's no clinical trials that I've seen that have tested that combination in that setting, and it needs to be done. But it might. I'm still open to the possibility that it works. Frankly, I'm a little skeptical at this point. All the trials that have been done show no clinical benefit, so it's narrowing the use case for it. But there is still some use cases left that to be tested.
Okay, and now let's talk a little bit about the vaccine and what's going on with that, and how quickly we've come up with a vaccine or working on the vaccine.
Sure. The speed at which we've come to a phase 3 clinical trials for the vaccine has been breathtaking. It usually takes years for a vaccine to get developed and approved. But whereas with COVID-19, with SARS-CoV-2, we're basically 7 months in since they started developing the vaccine, and we're already at a phase trial. So that's really fast. That's really fast, and a lot of that has to do with Operation Warp Speed and the effort to get one out. What they're not doing, and this is a point that I really want to make clear, what they're not doing is they're not cutting safety corners here. So in order to get a drug approved, it needs to pass through three phases of clinical trials. And the first trial is usually to assess safety. The second one is to see if it has an effect, and the third one is to see if it has an effect. It has an effect, and it's better than doing nothing. And we have to the vaccines that are in these trials, or the vaccines in Operation Warp Speed, have to go through all three phases, and they also have to enroll at least 30,000 people, at least 30,000 volunteers in the phase 3 trial. So that's a lot of people who's going to provide a lot of safety data. So it's going to be fairly safe as far as drug development goes. Obviously, I can't say with 100% certainty, but it's going through the proper safety measures, and it's going very fast. And we should all see this as encouraging news. I haven't seen any studies that have verified that, but for one, it does kind of make sense. Most things are kind of dose dependent. If you get exposed to a low amount of virus, then it's not going to you're probably going to be able to beat it back before it replicates enough in your body to really cause any severe illness. And I think this is going to be speculation, but I think that the reason why so many people with mild illness is that they get exposed to a very small amount. That would be from the pre-symptomatic spread that I talked about earlier. People who are young with healthy immune systems getting exposed to a small amount are probably developing an immune response to it without developing severe illness. But that having been said, I think once you get past a certain critical mass of the virus, then you're going to develop the disease. And the way the disease course will manifest itself is going to be more dependent on the person than on the amount of virus. So below a certain threshold, I think you just develop, if anything, a very mild case of the disease. Above that threshold, then it depends more on the person and the characteristics of the patient than on the amount of virus that you have gotten.
And shifting a little bit to more public health policy, and how at the beginning of this, the goal was to flatten the curve. Can you just elaborate on what that means to flatten the curve, and if we've done it, if anyone has done it correctly?
That we've talked about is it's unfortunately, this is another thing about public health messaging, is that the curve that we've talked about, the definition seems to keep shifting. But the earliest definition of the curve was the number of cases such that it would not overwhelm the health system. And I think as far as that goes, we've been tremendously successful. We really didn't just flatten the curve. We sort of sliced the top off. If you look at the number of cases, of daily cases from the beginning up until April, it's steadily climbing. And then on April, I forget the day exactly, but early April, it stops, it peaks, and then it it concaves downwards. What you would expect if you were just flattening the curve, you'd expect to see a gentle inflection point, but we don't see an inflection. We don't see a hill. We see a sharp cutoff right there, and that means that we did a very good job with the mitigation efforts. Now that came at a great cost because that drop off came from the lockdowns. So and the lockdowns had tremendous economic effects, and the economic effects translates to other public health issues. So such as depression, hunger, starvation, that kind of thing. There's a lot of other things that are happening. But as far as COVID-19 goes, we did a very good job with these mitigation efforts, and we did quite a number on the curve. Um, People who are still citing the curve as flattened, they don't really have a point unless they're talking about the second surge of cases that we had in July, and I think that happened because Americans got too complacent. I think maybe we were too complacent from our successes from April, May, and June, that we just started packing back out into the streets, into the not clubs, but bars and restaurants, stuff like that. People were just not being careful, and so all the new cases are surging in states that didn't have surges back in March and April. California, Texas, Florida. Those are states that you would have expected a large number of cases because of how populous these states are. But they didn't have spikes in the early part of the pandemic, but they did have it back in July. So I think that those are just the cases that happened that were prevented from happening earlier on. So now that we're starting to come off of that spike, then I think the curve is going to start heading back to where we were back in late April. And I think we've done a very good job mitigating the effects of this virus, and it's time to start getting our lives back to some semblance of normalcy.
Totally. All right. So I think that that is about all the time we have left. Is there anything else that you think our audience should know that we haven't mentioned, or just anything they should know to be more healthy, better informed citizens?
Sure. One of the most important things to know is that everyone dealing with COVID-19 in their personal lives or in their policy making, it's going to be a very difficult decision that you're making, whatever the decision is. This is a new situation, it's unprecedented, and it's difficult for everybody. So I think one of the best things we can do is extend a little bit of grace towards one another. There is a lot of anger and angst about people who have an opinion about schools opening, an opinion about the lockdowns, an opinion about this drug or that drug. We all want to get out of this together and intact, and it's not going to help if we keep shouting at each other. And we need to extend a little bit, and especially decision makers, they have tough, difficult decisions to make too. So if we understand that, I think it'll help us to understand what's happening a lot better, and that's going to help us get through this with a little more sanity intact.
We're all in this together. All right, Dr. Pham, thank you so much for your time and insight, and thank you for joining us today.
Absolutely. Thanks so much for having me on.